Hello, everyone. My name is Varun Jain, and on behalf of the Communications Committee of the ASMBS, I'm bringing to you another SOARD Spotlight. Today, I have with me Dr. Jerry Dang, who is the clinical fellow in advanced laparoscopic surgery, bariatric surgery, and flexible surgical endoscopy at the Cleveland Clinic, which he will be finishing up in a few months. Today, we're talking about the article from the March edition of SOARD, which is predicting serious complications following bariatric surgery in geriatric patients. Development of a GeriBari scoring tool using the MBSAQIP database. I have to say, it's definitely a very catchy and apt title indeed. Could you share the motivation behind this interesting project?
Thank you, Dr. Jain, for involving me in this. This is a great initiative. The reason why we did this study, we had published a few other predictive tools. And again, we tried making catchy names like the Bari clot tool. But we wanted to look specifically at the elderly population, who we defined as over 65 years of age. And we wanted to see, could we predict serious complications in this population? Like what factors preoperatively could we use to predict patients who are at higher risk? I think patients in this geriatric age range can benefit quite a lot from surgery. And even during my fellowship, we've operated on a lot of patients who are over 65. And it's nice to know, like, what is their risk, both for us to decide whether surgery would benefit them, but also to for informed consent of the patient prior to their decision to pursue a life-changing procedure such as bariatric surgery.
Absolutely. Okay, yeah, and I will agree that we are definitely seeing, as we see patients in the clinics, the average age, you can tell, while we have a good proportion of younger patients, there are an increasing number of elderly patients who do need and could potentially benefit from surgery. So, I mean, I think it definitely is relevant. So, I went through there are obviously multiple parameters that you kind of found on your multivariate analysis that are predictive in some capacity or another. And obviously, that's something that will be talked about more in detail in the paper. But is it something that you think can be converted into a simple click-through tool, online tool, where it can be used routinely for, say, clinic purposes when we're trying to evaluate what risk someone is at?
I think 100% it could be created into an online tool. We unfortunately didn't do that
Sure.
With the initial publication. We did try that with the Bari clot tool, and we did have a website. But just maintaining the website and like paying for all the fees over the few years that we had it, we actually didn't even keep that one up. Gotcha. So I think it is useful. But on the other hand, the tool is pretty simple to use. You just have to calculate the number of points, and then you use the cutoff, and then you can determine if the patient has a greater than 6% or lower than 6% risk. So I think we've made the tool fairly simple to use, although, the easier you make it, the more people will use it. So I think that's an important consideration to make a tool online, but we just don't have the funding to maintain a tool like that over many years.
Gotcha. All right. What do you think is the main clinical relevance for the tool? So would it be, say, decision for surgery, choice of surgery, or more from a counseling standpoint regarding risks for surgery for that particular population?
Yeah, I think it helps to decide on the procedure as well, because one of the factors was that bypass had a higher risk than sleeve. So I think if a patient has other risk factors, we have 12 different risk factors. But if their risk factors plus bypass puts them at high risk, then I think we would consider doing a sleeve instead. Or if, they just have comorbidities that put them at high risk, then we may either not do surgery or consider other procedures, like endoscopic procedures or whatnot. I think it's really helpful just in deciding and in informing patients.
Good. Excellent. Well, anything else that you would like to share with us that you think is just important to highlight, or if it's something that may not necessarily be apparent to readers just from the text itself?
I think the tool is useful. I think people should be using it in their clinics. I'm obviously biased because I was a part of creating the tool, and it is kind of named after myself because my name is Jerry. But I think people should try using it, see what they think of it. And I think we should be offering bariatric surgery to the geriatric population, especially the ones who, would benefit the most from it.
Excellent. Well, I'm looking forward to using it in my clinic. I'll see how that works out. And just out of curiosity, I would definitely like to see what risk stratification patients land up in. But I would like to thank you for taking out the time to speak with us, sharing unique insights on the topic and the article. It was a pleasure talking to you, and I really enjoyed the conversation. Good luck with finishing up fellowship and life ahead.
Thank you so much, Dr. Jain. Thanks so much for having me.